This is Donald. He's a 72-year-old gentleman who says he's still working, but he does a remarkable amount of golf in Florida for a man who's still working. He has a past medical history of hypertension. It's well controlled, atrial fibrillation. He's had a cholecystectomy 10 years ago and renal stones 5 or 6 years ago. And he's come to you in the middle of your morning clinic with 5 to 6 hours of really severe central chest pain. It's the worst pain he's ever had, with a slight radiation over to the right side. But over the last couple of hours, he's pain-free, and he's feeling a bit seedy. He's not eaten anything this morning, a very slight nausea. And when you examine him, his vitals are normal, and you examine his abdomen, and essentially it's normal. You can't really convince yourself there's anything significant going on there. His Murphy's negative, there's no masses, his femoral pulses are equal, good volume, his bowel sounds are present, and you do a urine dip because of that history of kidney stones, and there's nothing on it. So what do you do next? Let's do a quick poll. There's a few options here. Option A, do you take bloods, give him an antiemetic, issue with him a worsening statement, his pain's better, come back and see me if it gets worse? Who would buy into that? 1 or 2 hands going up. Me too. Next one, take bloods, antiemetic, refer him for an urgent outpatient ultrasound. He's got these gallstones in the past, the gallbladder's out, but he's got kidney stones. Might make you feel better if he had a scan. It might pick up anything obvious. Who thinks that might be a reasonable option? 1 or 2 hands going up. Okay, option C. Not sure what's going on with this guy. He's got kidney stones. I don't really know what's going on, but I'll phone up the urologist and see if I can convince them to take him. Does anybody think that's a good idea? No one at all. Okay, and finally, who would discuss this with their general surgeon? Oh, option D, excellent, lots of hands going up. Okay, well, I'm going to show you another graph, and this is another survival time-dependent graph. You'll be overloaded with these from this morning, but essentially survival is on the y-axis, and across the bottom is time. And what you can see is that basically every 12 hours that pass, the mortality rises significantly. So by the time you're 72 hours out from this presentation, almost everyone is dead. Does anybody know what this is? Perforation. Any other takers? Ischemic bowel. Excellent. Ischemic bowel is. Someone said AAA previously, and actually when you look at the survival for AAA, the graph isn't as steep as this. People do better from AAA because some of it walls off than they do from ischemic bowel. So this is a patient with acute mesenteric ischemia. So Donald has had severe pain, and he's now pain-free, but there's lots of badness going on inside. So firstly, acute ischemic bowel is rare. It accounts for less than 2% of acute abdomens as a whole. But once you move into the population who are over 70, it subsequently accounts for 10% of acute abdomens. And what happens is that generally the superior mesenteric artery becomes blocked. And when that happens, the muscle and gut go into overtime, and you get hyperperistalsis. And you get this perfect storm of ischemia, where all the remaining nutrients are used up, and very quickly the bowel wall infarcts. And basically, after about 5 or 6 hours, the infarction is complete. All the nerve fibers in the gut are dead. And it's not that Donald's got better, it's that actually he just can't feel what's going on down there. And at that point, there's a massive translocation of bacteria from the gut looming into the wall, and a huge surge in inflammatory response. And then over the next 6 to 12 hours, he's going to develop bowel gangrene. And then beyond that 12-hour period, his bowel will rupture, and he will then develop a perforated viscus with all the peritonitis and the signs that go with that. So Donald is in this window of quietness before the storm will hit. So we've got some guidelines on this, fairly new guidelines. This is from the World Society of Emergency Surgery, published in August 2017. And I'm going to quote direct from this because it's quite a powerful message. Severe abdominal pain out of proportion to physical examination findings should be assumed to be acute mesenteric ischemia until proven otherwise.